I'm going to try to keep my voice going until the end of this presentation. All right. It's great to be here today to get to share with you the work I've gotten to be a part of over the last 7 months during my practicum at the Pacific AIDS Network and their community-based research program. So the Pacific AIDS Network is a member-driven network assembled to provide support for their member organizations' efforts in responding to HIV, AIDS, hepatitis C, and other related diseases and conditions in British Columbia. I was really lucky and I got to be a part of many different projects while I was at PAN, but for my final project, which is what I'm speaking about today, I worked closely with PAN and the forum's mental health, substance use, HIV, and hepatitis C research team, and conducted an environmental scan of case management and community development and community capacity building models, supporting people living with multiple intersecting vulnerabilities, including mental illness, problematic substance use, HIV, and/or hepatitis C. The purpose of this environmental scan was to help inform the research team in the beginning stages of a project to further understand the roles of community-based organizations in both formal services and in community development and community capacity building, as well as to explore the potential advantages of overlapping these often quite separate areas of service. Community-based organizations take on multiple roles in supporting this population, including implementing best practice models of integrated care and acting as community developers, helping clients build skills and develop social networks to support their well-being once they graduate from formal services. So when I say implementing best practice models of integrated care, this could mean a variety of different programs and services. But for this project, I focused on case management models. And for the purpose of this environmental scan, I use the term case management to describe a variety of models that offer client-centered support, helping clients navigate complex systems and linking them with healthcare, psychosocial, and other services required to maintain continuity of care and meet their health and human service needs. So I use a broad definition of case management in this case. The next important thing to define is what I mean when I say community and community development and community capacity building. When I say community, I'm either referring to a group of people that share physical spaces or common experiences or traits. Community development and community capacity building intend to support groups, individuals, and organizations by building skills and competencies and mobilizing assets to support community members in their progress towards active, sustainable, and socially just communities. In this environmental scan, I searched for, described, and summarized a variety of different models of both case management and community development and community capacity building. Most of my models came from BC, with a few exceptions from the rest of Canada and internationally. The information I share in my report comes from secondary analysis of grey literature that I identified by speaking with members of the research team, through conversations with other key informants from across BC, and you see their organizations represented on this slide, hopefully. Also through internet searches using Google and UVic Summons website, and through the KT's Programming Connection, which is Canada's AIDS Treatment Information Exchange, and it's a great resource offering case studies of Canadian frontline practice models. I use that extensively. The examples I chose were to reflect a variety of models from both urban and rural communities. First, I summarized information in tables like you see here. The information I included was program overview, the organizations involved, program goals, eligibility and recruitment, scope and duration of engagement, required resources, any evaluations that have been done, strengths and barriers to access and implementation, and any client experiences if they were available. Next, common themes and strategies were identified, and opportunities for overlap between case management and community development and capacity building models were discussed. Since my environmental scan ended up being 70 pages long, sorry, Kathy and Lynn, I created a summary document to share with the research team and any other interested organizations or community members. So it looks something like this, and I do have a few of them down here for anyone who's interested. It's a 4-page summary, and it provides a brief overview of the scan and summarizes the purpose, results, and my discussion as well. In total, I described 10 case management models and 10 models of community development and capacity building. This is from the summary document. The list I included was not meant to be a comprehensive list, but rather to provide a variety of examples and programs to present the research team with a diverse picture of strategies and best practices being used. Next, I pulled out strategies from each model and grouped them into main themes. The main themes I pulled out among the community development and community capacity building models were, first, a focus on community assets, not deficiencies. So asset-based community development, which we've heard already about today, focuses on the strengths of communities and how these resources can be used and expanded productively to benefit the community. This is in contrast to development efforts that focus on deficiencies in community and can actually act or contribute to community members acting as consumers instead of producers. The involvement of peers and allies was another important one. Peers are people who share similar life experiences with program participants and can offer a unique set of skills and experiential knowledge that many healthcare professionals cannot. People may find it easier to trust and relate to those who come from similar backgrounds or share similar experiences. And non-professionals may be able to share some responsibilities to relieve strain on overburdened or under-resourced systems. Skills and competency training. Skills training intends to develop participants' capacities to support their own well-being and that of their peers. Examples include leadership courses, workshops on stigma and discrimination, resiliency training, and many others. Culturally competent and flexible programming. Different communities have different priorities, capacities, and systems of development, and understanding the cultural climate and including community members in the entire process results in more effective programming. Among the case management models, the main themes I included were strategies of accessibility, including outreach services, drop-in spaces, 24-hour support, and the option for both scheduled or drop-in appointments. Again, the involvement of peers of allies, which I already spoke to. Client-centered flexible care plans designed in consultation with clients themselves. And holistic psychosocial focus, including support for social determinants of health, so housing, food security, social assistance, and support with mental health or substance use issues. As part of my analysis, I consider some of the possible opportunities for integration and overlap between some of these strategies. Firstly, task shifting, so addressing limited resources by delegating tasks to non-professionals and benefiting from skills and assets of peers. One challenge in integrating community development and capacity building agendas into formal services is that teams are often already struggling to manage their workloads, and adding additional responsibilities is often unrealistic. Task shifting is therefore an important tool to consider when adding to and integrating these areas of service. Next, mentor-mentee networks, where peers and allies are paired in supportive relationships to develop skills and accomplish goals. The Legacy Project in Toronto, which I included in my scan, is one such program, where this network of mentors and mentees really forms a supportive community outside of formal services. The Smart Recovery model is another model that I thought was interesting, and it's an addictive behavior recovery program that includes a worldwide supportive community through online meetings, chat rooms, forums, as well as in-person meetings. And they also hold trainings for leaders to host their own meetings in their communities if they aren't already being held. This example is specific to addictive behavior right now, but it has been suggested that the model may be adaptable to support a wider population. Some examples of community building activities that could be built into formal case management programs, if the capacity exists, include community resiliency training, which consists of sustainable teachings, giving people the capacity to support themselves and others in their community. Community gathering events aimed at reducing stigma, creating community cohesiveness and awareness, and low barrier drop-in spaces, offering formal services as well as a place for communities to gather. Understanding the opportunities for integrating community development and community capacity building strategies into formal services is something PAN and the formed Mental Health, Substance Use, HIV, and HCV research team is focusing on. The intention is to close gaps that exist when people are released from formal services for those who may not have adequate personal support systems in place. An important theme that I identified in both the case management models and the community development and capacity building models in this scan is the benefit of engaging peers and the effects this can have in removing some of these barriers. The information gathered in this environmental scan was to help inform the research team in developing a Canadian Institutes of Health Research Catalyst Grant application and will hopefully further help the team in their research if the grant is awarded. I would like to send out a sincere thank you to my practicum supervisor, Janice, who hopefully made it online, and Andrea Langlois from PAN as well, the whole research team, the key informants that took the time to speak with me, to offer up suggestions, both my first and second reader, Dr. Kathy Worthington and Lynn Davis, and for practicum support, Victoria Barr. Thank you.
Thank you. Okay, you know the drill.